Hello, my name's Corey, and this is my video portion for the class assignment on schizophrenia. I will first talk about schizophrenia, and then I'll go into the reflection on scenario 2, which I chose, and I'll try to be as quick as possible. It's a lot of information, but a brief description of schizophrenia, which is our topic, and also the case study that we did on Sean, 24-year-old with schizophrenia. So a basic definition of schizophrenia is it's a chronic mental health condition that is characterized by disruptions in thinking, perception, emotions, and behavior. This can last for 6 months and at least for 6 months without being treated, and affects daily functioning. Some positive symptoms would be delusions, hallucinations, disorganized thinking, motor behavioral skills, and negative symptoms would be social withdrawal, reduced motivation, flat affect, diminished speech. There's also cognitive characterizations, symptoms, impaired mental processes, difficulty with attention, memory, normal functioning. So that's a basic overview of schizophrenia. And there's also genetics that play, environmental factors. The medication that I chose to treat Sean is Abilify, or aripiprazole. I'm not great at pronouncing words, these big words, but I'm just going to say Abilify. It's an atypical antipsychotic, second generation medication that's approved to treat schizophrenia and some other conditions, and it works in the brain to help reduce psychotic symptoms such as delusions and hallucinations. How it works: it's a partial agonist at the D2 receptor level, so it can stimulate D2 receptors when dopamine activity is low, and it can also block, so it stimulates and blocks dopamine activity when it's high. So it can stabilize dopamine signaling, and it's a partial agonist at the serotonin level, at the 5-HT1 receptor. This contributes to mood and anxiety, manipulation, and can help reduce the negative symptoms and cognitive aspects that schizophrenia causes. So it's also an antagonist for 5-HT2A receptors. It blocks these receptors, which helps reduce psychotic symptoms. So the overall effect that Abilify can have on Sean would be by balancing his dopamine and serotonin pathways, and hopefully reduce psychotic symptoms, which potentially cause fewer movement-related side effects compared to the first generation antipsychotics. So that is a brief description about schizophrenia and why I chose Abilify to treat Sean. So in the scenario 2, well, in the reflection, I chose scenario 2, and this involves a patient's been stable on antipsychotics for 6 years and developed new involuntary movements in the face and mouth, such as lip smacking and grimacing, after a hospital stay where he received metoclopramide or nausea. So these symptoms, correlate with tardive dyskinesia, or TD, and this happens because of long-term blocking of a brain chemical called dopamine. So this can cause the brain circuits that control movement to change in ways that keep producing these unwanted movements, even after the medicine has stopped. So this is what the patient in scenario 2 is experiencing. And what I was thinking I would do would be to check how severe the TD is using a simple movement checklist. An AIMS checklist is a great one to use. Review his current medications, including the recent metoclopramide, and make sure that there aren't any other conditions to rule out that could look like TD. Some treatment options. If possible, I would slow down or switch the antipsychotic that he's on to one with a lower risk of TD. If the TD is really noticeable and needs treatment, medicines called VMAT2 inhibitors would be considered that can help reduce the movements. Examples of this would be valbenazine or a tetrabenazine. The valbenazine, you start at 40 milligrams, typically once a day for a week, and then double the dose to 80 at once a day. And the tetrabenazine, you start at 12 milligrams a day and then increase that gradually as needed. Sometimes a small amount of unrelated medication for movement symptoms can be prescribed, like an anticholinergic. That can be used if other movement side effects occur. If an anti-nausea medicine is needed in the future, definitely avoid the metoclopramide, and I would choose a safer alternative. So reflecting on TD and its neurobiology, it's a good reminder for myself that patients' experiences is not a failure on their part or controllable with their will or character. It's actually a complex combination of their brain circuitry, the medications that they're on, and their individual history. If I can stay focused on viewing their symptoms through a neurobiological lens, that helps me to approach my care with patients with humility and curiosity and support. Improvements in the patient may be gradual, it may be accelerated, and many times it's not in the exact clinical straight line that we would hope or expect. So everybody's different and individualized. So I think having this perspective with treating patients, especially who are experiencing TD, well, all health conditions and disorders, adverse effects, this deepens empathy in myself and acknowledging what they might be going through in a situation that's impacting their speech, movement, mood, and daily life. And so this perspective I would strive for it to guide myself in explaining options clearly, to validate the patient's experiences, and to make sure that I'm engaging them in shared decision making. So, and then reflecting on my own feelings about the risks, side effects, and complexities of the medication, and how my own feelings could shape treatment discussions. I think I would recognize that my caution or optimism, it does subtly steer conversations and influence shared decision making with the patient. So I need to be careful if I'm weary about potential harms that I don't overemphasize the risks, trying to influence, because that can heighten patient anxiety and narrow the range of considered options. And that might compromise their true autonomy. But on the flip side, if I have a lot of enthusiasm for a certain therapy, that could also pressure patients towards that choice, diminishing their sense of control. So I want to strive to be balanced in my presentation of treatment options, use evidence-based information and acknowledge uncertainties, and invite patients to articulate their goals and their values. And then if I can use neutral language and check in with their understanding of their treatment options, and use decision aids if needed, that would be the best way to go about keeping that balance. And then reflecting on my own biases, I think I would strive before I interact with the patient to remind myself that this is about patient-centered care. The conversation dialogue is patient-centered, that's why I'm there. So I would, or I can support informed choices that align with the patient's priorities to preserve their autonomy and build trust within the relationship, the patient-provider relationship. So there was also a question or a note that said I needed to comment about if TD is an allergy. It is not a true allergy, but it should be documented as a medication-induced movement disorder, and note that we're stopping that or changing the dopamine blocking medicines, and this should be done really carefully with alternatives in place as needed. So this would help guide future care without hopefully limiting options. So that's all I really have. I tried to make it as quick as possible. Thank you, and I'll see you next time.